You're listening to the Cancer Assist podcast, hosted by Dr. Bill Evans and brought to you by the Cancer Assistance Program. Wherever you are in your experience, we're here to provide help and hope as you navigate cancer prevention, treatment, and care. Help when you really need it.
Well, welcome to the Cancer Assist Show. I'm your host, Dr. Bill Evans, and today we're going to be talking about planning within the regions of cancer care delivery within the province of Ontario, and speaking specifically about the regional cancer plan in the Hamilton, Niagara, Haldimand and Brant region. So for some of you listening from places far away from Hamilton, you may wonder, why should you listen to this particular show? Well, I think there are many reasons, and the plan has evolved over multiple years and has increasingly focused on the quality of patient care and the experience of both the providers and the patients in delivering cancer services. And we're going to be speaking with the regional director. But before I introduce her, I want to just say a few words about the Cancer Assistance Program, which provides a variety of free services to cancer patients in our region. These services include free rides to the cancer center and to other medical appointments, loans of free equipment such as ambulators and wheelchairs and rollators and so on, and other things such as nutritional support, urinary incontinence supplies, mastectomy bras, and head coverings, just a variety of things that really help cancer patients get through the experience of cancer. And we really want to thank the Hutton family for their support of these podcasts. They wouldn't happen without them, their support, so we're really indebted to them to make this possible. Now I'd like to introduce Jennifer Smyth. Jennifer is the current Vice President of Regional Cancer Programs. I think I got that right,
yeah.
Close. And she has an interesting career path to get to that position. And I'll let her tell you, but I'll tell you she starts by being a dietitian. So how did you move from dietitian to directing regional cancer programs, Jennifer?
Yeah, that's a very good question, and thanks for having me today, Dr. Evans. So when I was actually in school completing my internship to become a dietitian, one of my first placements clinically was at the Juravinski Cancer Center, working with the dietitians there, particularly in the head and neck cancer disease site. And at that moment, I decided the cancer system is actually where I want to continue my career. And I loved everything about the environment, the impact, the quality of care, the systems level coordination for those patients as they have their surgery at one center and then come up to the Juravinski for another. I was really intrigued by kind of the bigger picture of how we coordinate care for cancer patients, even though my scope was making sure that they stayed adequately nourished through their cancer treatments.
But you took a bit of a detour.
Yeah, that's right. So from there, though, career life takes you different pathways, and then I ended up working at Joseph Brant Hospital, which is one of the partner sites in a regional cancer program. And in that, I worked in the surgical program, dealing with some surgical oncology patients, seeing a different side of the cancer system and treatment there. And then had the privilege of working in that level 3 chemo suite as well, and really got to see the complexity of care required for their patients in a level 3 site or a community level organization. So had some kids and came back through that. And during that time when I was off on maternity leaves, I thought, I love my career in healthcare and I can't see myself doing anything different, but I do love the idea of being able to have a more bird's eye view of how we're influencing the quality of care for our patients and how we're leading some really great initiatives to support our patients, our providers, our frontline staff to improve and continually challenge ourselves to deliver a better model or a more seamless model. So did some initial leadership training and courses and got a great opportunity to step into a leadership position there, managing the oncology clinic, ambulatory care portfolio, and endoscopy, so another screening portfolio for the cancer system. And from there, was able to partner through the network of the Regional Cancer Program, which I think we're very lucky in our region to have such a strong framework of governance where we meet regularly as a program with all of our partner sites, and we ensure that we do keep ourselves accountable for the quality and access of care for patients in our system. And from there, I was given an opportunity to consider coming into the director position for the Regional Cancer Program and Complex Malignant Hematology portfolio, which felt like a scary move, but it was
challenging.
A pivotal moment for me. It was really great. I think it reflected my personality, where I'm always looking for a new opportunity to learn and challenge myself and grow. and also another added opportunity to go that little bit higher to see a different level of our cancer system when we're looking at outside of our region now, not only Hamilton, Niagara, Haldimand and Brant, but on the hematology side, looking with Waterloo, Wellington, and Erie, St. Clair, and Mississauga, Halton, Central West. And it gave me an opportunity to come to provincial tables to really see what's going on in the rest of the province. And
so your heart's always been in oncology.
That's right.
Just took a while to sort of settle in and
Find my
into
path.
An important leadership position within the regional cancer program. That's great. So we're going to talk about the regional cancer program, and I have a history with it too, because I was at provincial office at the time when Dr. Alan Hudson organized the first cancer plan, and it was for the GTA. But that was sort of the spark that lit the bigger fire to do planning across the whole province. And in those days, the problems were pretty significant. We were short on cancer centers, radiotherapy equipment. There were long wait times for access. So some of the focus of the early cancer plans was on just correcting some of that capacity. It seems to me that over time, the plans, which are on a 3-year planning cycle, have broadened out to other areas of focus on screening, the introduction of the colorectal screening program, diagnostic assessment units, but increasingly a focus on patient experience and making the plans more patient-centric, and now quite a focus on equity, as I see it. So there's many dimensions to these plans now. Actually, there's so many things you're working on. It must be a bit challenging to keep all the balls in the air, and we don't have time to talk about all the elements. But maybe you give us a little bit of an overview of, first of all, sort of the key things in the regional cancer plan for this region, and some of the first-year initiatives and how you're doing at it.
Yeah. So whenever I talk about our regional cancer plan for our region, in my mind, I always organize our work from screening and prevention through to diagnosis, treatment, palliative care, end of life, and all of the complement of psychosocial oncology and supportive care measures that are required to support those patients across that continuum. And I think that's one thing that I've been very clear with our regional leads and our team, that I really want them to think the same way as well, versus instead of just looking at the silo of the program that they are responsible for, is about the interrelationship between the different programs and how we're supporting patients across that entire journey. So when we look at, as you mentioned, a key theme in this regional cancer plan is equity. And one of the things that we've done on our cancer screening side of the house is really taken an opportunity to focus on expanding those programs and ensure equitable access to quality care for all of those programs. And the most important point of that is then the diagnostic pathway following those screenings, should something come up that might be concerning. So in our current state, what the team has done is created really robust pathways for patients to navigate timely assessment from a positive screen. But what I think we can do in this plan, and what a focus of our attention is how do we still support those patients about how concerning and how challenging it can feel to get a call saying something concerning came up on your mammogram, or there was something that we need to investigate further from your colonoscopy, and this is what's going to happen next. And, for patients, when we think about how are they going to get to, that biopsy or their blood work or their follow-up appointment or their initial consult, we don't really wrap around the patient yet to support them in that journey until they actually get that formal diagnosis. And what we've heard from our patients is that's actually the most stressful time for them, when they're in that waiting period of the fear of the unknown, and you're trying to get the diagnostics ordered and get to those tests. And I think for us, a big priority is figuring out how we can support patients at that really pivotal point in their journey as well. They may find out that nothing is concerning, and it was false positive or benign or something that isn't worth further. Maybe they go into a surveillance pathway, but we still want to make sure we're supporting them and having those conversations, because that, for many patients, that is the entry point to their cancer journey. And how do we make sure that we are facilitating connections for those patients and their loved ones at that point as well? So that's a big piece of it. And the second piece is then the equitable access. So, we had a lot of success with our initial hub site of our Ontario lung cancer screening program at St. Joe's. And that program exploded. There is so much demand for it, and I think it had a hugely successful year, and we're extremely proud of our partnership with St. Joe's. And Dr. Christian Finley has been exceptional with helping us spread the word and get the messages out about the importance of this, that we're actually onboarding 2 new spoke sites to this model this year, hopefully to go live in March, one in St. Catharines through Niagara Health System and one in Brantford. And then future sites are already emailing with interest and engagement, and there's a lot of attention. And the one thing I love about this is what we're seeing early is that low-dose CT is detecting early cancers and is getting patients into the system sooner rather than dealing with a stage 3 or 4 lung cancer that puts a huge strain on the system and, creates a worse experience or potentially impacts the quality of care of those
and
patients.
Importantly, it's a chance to cure the lung cancer,
That's
which
right.
you don't get many chances because lung cancer is pretty silent. So
Yeah.
But the focus on equity, some people might be listening and saying, well, surely, if the care must be equitable across the province or across the region. What I get in this region in Brantford or St. Catharines or Joseph Brant Hospital in Burlington, it's the same as I get in Hamilton, right? Mm-hmm. But is that so? And
It is very much so that equitable access to care is available across our region, and I do recognize the privilege in our region where we have such great resources with our level 3 partnerships and the level 2 site in Niagara as well. And I think what we need to do is build trust in the reputation of those programs as well, where patients can feel confident that the quality of care they're receiving at those centers is the same as what they may receive at the Regional Cancer Center, the JCC. And through that, we're actually using our current partnerships with these organizations to enhance our quality frameworks that focus on education, access, organizational readiness for adoption of new therapies to ensure that as a team, a program across our 4 sites, we are all leading and stepping forward in the same way to provide equitable access to new treatments for our patients. So I think that's something that is new, where we did have those partnerships. Patients could access care close to home, but now we're just taking it up another level to say that we are committed to ensuring equitable access for those frontline nurses to receive the same type of education and support and competency development and ongoing assessment of the quality of services that are being delivered at those sites so that our citizens in our region can trust the reputation of all of our partner programs.
Maybe you need some way of demonstrating that this is a site that's been accredited
Yes.
by the Regional Cancer Program as a level, a certain level of competency or something that displays to the public that they are trained up and that they can have confidence in the care that's being delivered. But of course, when I think of equity, I think about disadvantaged populations in the inner city, the lower socioeconomic status individuals, lower health literacy. I also think of our Indigenous populations, and often the access of those groups of patients is less than equitable. And I know there's a lot of work going on to try and rectify that. Maybe you'd like to talk about that too.
Yeah, so we have been heavily partnering with our Indigenous Cancer Program team, of which we are fortunate to have a great navigator, a coordinator for the team, and then our regional Indigenous cancer lead as well. And we've been leveraging that team to help develop our own regional Indigenous cancer plan that builds off of the provincial Indigenous cancer plan. And with that, what we're really trying to focus on is building those partnerships to make sure that we are understanding the needs of those communities to improve access. The one piece that always comes up is how we can provide more care close to home for them, whether it be within their community or, within a reasonable distance for them to be able to access that. And while there are some things that must come to a cancer center or a larger center, there's a lot of care that can be provided in community. And that's what we're hearing is the needs for them. So I think a big component of our regional cancer plan is figuring out what is the art of the possibility of providing care within community for our Indigenous patients, and then making sure that we are recognizing the unique needs of those patients as well across the care continuum. So a big focus of our team has been supporting access to traditional medicines for these patients as at important parts of their journey as well. And working with our internal procurement teams and community vendors of these products, of these medicines, to support access for patients so that their needs are being met even if they can't receive care within their community. So really trying to make sure that we are supporting them and providing the care that they would wish to have regardless of the location. And then another piece of that is supporting them with different resources where they can lean on someone who is also Indigenous. So trying to really expand a service and the network of Indigenous coordinators and navigators across the region. So whether it be at Niagara or Brantford or Joseph Brant, really creating a strong community of practice across those teams to make sure that they're providing the same level of care for those patients should they have to go to one of those centers.
Maybe just talk a little bit about Indigenous navigators and what their role is, and are they in other institutions beyond the Cancer Centre?
Yep. So there are Indigenous navigators at 3 of our 4 partner sites right now, which is great. And I think that's something that the organizations have committed to rebuilding that service and making sure that it is something that is accessible for patients within their own site. And what we're identifying as an opportunity now is to use the regional cancer programs team of Indigenous staff to really help elevate their understanding and improve the services that are being offered at those sites so that there is greater support across the region and more seamless coordination of care for those patients as well.
That's great. And you mentioned access to sort of traditional medicines, and I'm still struggling to understand some of that myself and trying to learn more, as we all should be under the kind of the Truth and Reconciliation initiatives. And are in the Cancer Centre, can a Indigenous person have a smudging ceremony, for example?
Yes. Yeah. So we actually just did the official launch this year on National Truth and Reconciliation Day of our Indigenous healing space within the Cancer Centre, and we're extremely proud of this space. And it's been sourced by local vendors from our own communities within region with their artwork and furniture and pieces, and it's really been outfitted to reflect their needs. They do have access to smudge, whether they be in the Cancer Centre or an inpatient unit. They're able to do that, and then able to prepare any of the medicines that they may require. So there's kettles and hot plates and things. What I've learned a lot about Indigenous communities is food is medicine to them. And the key learning for me was back in June, our team partnered with Six Nations and held an event where they recognized the importance of the strawberry moon and had a strawberry event with an element of health promotion and cancer screening opportunities, really tied to the importance of that food being medicine and the importance of that strawberry season. And really proud of the team for to support the development of that kind of initiative and really strengthen the partnership with our communities.
That's amazing to hear those things happening, and it's so important for Canadians to recognize what the Indigenous population has gone through over multiple generations, particularly the whole residential school situation and how they were abused in that and how it's affected multi-generations, and how we need to be much more respectful. And so pleased to hear those initiatives in the Cancer Centre. That's a definitely a big step forward. I'm sure well received by the Indigenous population in our region. But part of the problem too is we sort of expect people to come to healthcare facilities, and we don't often reach out to them directly. But this region is unique in having a mobile coach, which is a very interesting way. And I gather there's like 60 different places the coach has visited in our region. And talk about what's on the coach and what you're planning in the cancer plan, as well as newer initiatives to use the coach.
Yeah, our region is extremely proud of the success of our mobile cancer coach. So it's actually been on the road for over 13 years. So our coach, they don't have that long of a lifespan usually. So it's just getting by currently by some well wishes and duct tape to get up and down the 403. But we're extremely proud of those partnerships. The current services that are provided on that coach, so you can have mammography, you can have your cervical cancer screening. We are about to launch fit kits on hand for colon cancer check, which will be amazing. You can have cancer risk screening completed by one of our nurses, and even access to smoking cessation therapies as well, or nicotine replacement, which has been a key component of that as well. We've been very fortunate to receive funding from Ontario Health, Cancer Care Ontario, to procure a new mobile health unit. The PO will be going in place by the end of March, which is a really exciting time for our team, because what this also gives us is an opportunity to reevaluate our model, to figure out how we can support patients differently as well.
You did a survey, I understand, of people coming to the coach, and I guess the population in the areas where the coach goes, and got some interesting feedback, I think.
We've received some very interesting feedback about the services, and what we found from our modeling as well, and collecting some data, is it's a very female-focused service right now, and 96% of our clientele are female. So one thing for us, and it aligns to the mandate of Ontario Health CCO with the funding that they've provided as well, is to look at more prevention-focused efforts as well. So what else can we do from a population health perspective to, yes, one, get patients in to support their screening, and that will always be a key deliverable of our mobile unit, but how else can we support them, whether it be through vaccinations or mental health screening or, blood pressure checks, glucometer checks, the art of the possibility in terms of supporting overall health and prevention of what could be a lifestyle risk that could pose them for cancer down the road. And I think the one thing that we're hearing from those surveys time and time again from our communities and current users of the coach as well is they value that connection and that it's a different environment. You get to know the staff. People who go there once for their screening, they come year after year for their screenings there or when they're due. And I think it's really important that we do continue to leverage that, because I think if we are able to build in other services from a prevention perspective, what else can we do across the cancer continuum? So, we think about patients who, are on active chemotherapy and they're really struggling with symptom management. Mm-hmm. Can we build a model within that unit where there's nurses who are trained to support patients for managing their symptoms, or a nurse practitioner on the unit who can say, call in, we're going to support you through this, you're having this type of symptom, and we're going to actually wrap around you for the rest of your cancer continuum as well, should you have something concerning. So that's really the focus of our team right now. And then also taking an equity lens to that about, that has always been the mandate of the coach, is to support underserved, underscreened communities where screening programs that are traditionally housed may not be as accessible to our patients, and really making sure that we continue that as a key priority, but then thinking about the rest of the cancer continuum and how else we can add services or create a different model that provides a different level of service.
And I gather from the survey, some of the requests were for things that are non-cancer related, like STDs. And I was surprised to see that, but it's going farther afield from cancer, but nonetheless is what the community wants and needs. So might that be something that's going to be adopted in the future? Absolutely.
I think women's health is something we need to explore a little bit more, especially if we know that, that's a big proportion of our patient population, current users of the coach. If that is something that they are finding as a gap and is creating access issues for women who may need additional support for sexual health or STIs, I think we really do need to embed that as a part of our model. And the other interesting one that came up was vaccines. And that was really encouraging to see when you think about,
the misinformation in the airways these days.
That's right. And that came loud and clear. So when we're currently looking at what we're going to be procuring for a new unit, that is going to be at the forefront of our decision making to make sure that we have at least the potential to explore that in the future.
Yeah. Because that's a bit of a disappointment, the uptake of vaccination for HPV. And I gather from the recent modeling that we will not achieve what we had hoped to achieve by 2030 in terms of reducing the incidence of cervical cancer, very preventable disease and also highly treatable, found early. And yet the incidence is going up, and people are not getting the vaccination as they should. Mm-hmm. So it'd be a great opportunity to introduce that. Now, when you say 96% of the clientele is female, so I have to argue for male equity. How are you going to get more men to come to the mobile coach?
I think having the fit kits on hand would be a key component of that. So having the ability, and Ontario Health will be changing their vendor for the fit kits as well, which I think will be helpful, is patients knowing that they can come get it there and they don't have to leave with a requisition or mail receipt of that fit kit. I think that will be really impactful. And I think if we do a great job of community engagement, of sharing the word that you can come get that there and why you need it, that may attract people. And while they're there, we can do some cancer risk screening, and then we can talk to them about smoking cessation, and we can, if they're struggling, we could do a mental health screen and try to make sure that we do have those. A key mandate is the follow-up pathway to the coach. So we'll help you find out what's wrong, but we need to make sure that we have a good pathway of supporting you with the treatment or any intervention that may be required with that. So making sure that we do have those pathways and a good understanding of what's available in those communities, wherever the coach may be, so that we can ensure timely follow-up for those patients.
Well, a lot of men in the inner city smoke, and so our focus on smoking cessation would be really good thing to pursue. And I don't know anything about the willingness of just the average person in the inner city, their the receptivity to cessation, that may be their comfort and pleasure in life. But nonetheless, finding a way to kind of promote smoking cessation from the mobile coach seems like a great idea to me. Of course, I'm biased.
You're allowed to be.
Well, it's a problem we really need to address, and it's a powerful addiction, and I feel badly for the people who get addicted because it leads to a lot of ill health that could be avoided, and you really want to work hard to try and help folks see that and get them through the addiction. It's not easy. It's not easy. And that sort of brings us to, you mentioned it already, a little bit about the expansion of the Ontario Lung Screening Program, which is being rolled out across the province and should be in all the regional cancer centers by end of 2026. But it's a great screening site in St. Joe's. It's such an important thing because I think this region has the highest number of new lung cancer cases of any region in the province of Ontario. And so it's tremendously important that it not only be going well at St. Joe's, but also rolled out. And so there are plans, I gather from what you said earlier, to spread the OLSP more broadly.
And I think in addition to that, so yes, we're working with Niagara Health System to have a site at St. Catharines, and then also with Brantford as well to have a site at their institution. And I think the biggest piece of that is we are still sticking to that same screening, that assessment that happens at the beginning to really identify if the patient is at risk based on a number of factors, right? So age, 20-plus year smoking history, really looking at other comorbidities like BMI and COPD to determine if that patient does at least have a higher than 2% risk of a 6-year incidence of cancer. Yeah. So really sticking to that mandate. I think the volumes of patients we're finding is surprising to folks, whether they've been referred in through a primary care provider or through a self-referral as well. And we've created such a demand in our region, which has been really exciting to think that people are taking interest in trying to detect earlier cancers. To your point that you made is, if you catch it at stage 1 or 2, it's curable. Yeah. And it does. It impacts the broader system. It impacts that patient and their family and their care trajectory. And I think if nothing else, what it does is even if we don't find anything on that low-dose CT when we've initially completed it, it at least brings the patient in to start building that relationship where we can start having different conversations about other risk
like smoking.
Like smoking, yeah. And then also what other screenings they might be due for. And I think that's a big component of our screening programs is having those conversations with patients about what else they might be due for, whether it be colon cancer check or Ontario cervical cancer screening as well, and really making sure that we're building that in as a key mandate for all of our programs.
That's important because the original pilot, which I was involved in, particularly from the smoking cessation side, just focused exclusively on lung cancer, not about trying to educate those going through the screening program about what other screens would be appropriate. So that's a great addition. And spreading across the region, absolutely essential. So that's see the value of the regional cancer plan.
That's right.
Emerging here. So one of the things on the plan that caught my eye was the expansion of chemotherapy. I was going to say suite, but it's really the chemotherapy services because systemic therapy, we should call it systemic therapy rather than chemotherapy because there's so many different forms of systemic therapy, including immunotherapy and molecular targeted therapy, which are not chemotherapy, but they are chemicals, but it's not in the traditional sense of the drugs we started with in oncology. But it's just growing like wildfire. And the capacity has always been an issue. We never seem to have enough suite chairs and so on for all the patients that we need to see. And some of these, particularly immunotherapy administrations, take hours to deliver. And so there are so many challenges. But planning for a 10-year horizon seems to me to be a great challenge because mostly we can't see past a year with what will be the new products on the market that are valuable to our patients. So how are you going about that? It seems like an incredible challenge.
It feels very daunting because it does. We have some modeling from the province in terms of what our region may look like. And we've been kind of ranked by regional cancer centers about where the greatest demand will be for chemo treatment chairs by 2034. So when we ranked, and it's in a heat map, Juravinski Cancer Center is very, very red at the top of that heat map.
You don't want to be red.
No, we don't want to be red.
But you better do something.
That's right. So, and we were challenged. It's upwards of 40 to 60 additional chairs that we will need in our region by 2034, and that's a scary number to look at. And I think what we need to do is that's where we need to build on the strength of our region, where we do have access to, 4 compounding pharmacies that can produce cancer drugs to get patients access to care, and really leaning on our 4 sites to have a shared invested interest in this capacity plan. We're well resourced with chemo chairs in our region and in the art of the possibility for expansion. And I think that's really when we look at that, the Juravinski Cancer Center has just expanded to a 13-hour chemo chair time, which is great. And we need to do the same with our partner sites as well. I think historically, cancer treatment has been delivered in a Monday to Friday model on a shortened day, and I just don't think 9 to 5, and closed on stat holidays and weekends, and I think we just we won't be able to sustain that in the future. And so while we're developing that plan and looking at, whether it be disease site transitions of care to whether it be what currently is delivered at the level 1 site going to a level 3 in Burlington or Joseph Brant or Burlington or Brantford, is all of the other supportive services that go along with that as well. And that's where I think we'll need to continue to bring in, and the further development of this plan requires not only engagement from our partner organizations, but also from organizations like Cancer Assistance Program and CCS about how we are going to support patients accessing care in those regions as well and those other centers, because that's a big component of that. As soon as we start shifting care from one location to another, we do worry about how patients will navigate access to those sites as well. And it's something that we're going to need to keep a close eye on. The other thing on the chemo capacity suite is we've committed as a cancer program to stay ready to be early adopters of any new therapies. The challenges with that is having capacity to infuse those new therapies, or whether it be a sub-Q injection or whatever it might be. So we're always trying to stay ahead of that. So we've developed some really strong partnerships with our industry pharma partners to share what's coming, where things are at in the approval process, whether it be through price negotiations or Health Canada approvals, to make sure that we're always thinking strategically about where is the best place for that chemo drug to be delivered, and what's the optimal location, so that we can do a good analysis about what makes sense and where. So when we look at developing this plan, it's going to have to be sequential. Like operations, how do we expand across our region to make sure everybody is running at an extended day, consider weekends or stat holidays? How do we build capacity in our pharmacies as well for the coming drugs? And as we're treating patients longer and we look at survivorship, where are they in that? And then also the other impacting services. So what does this look like for lab or diagnostic services, patients who need those CTs every 3 months? What impact is that going to have from a capacity perspective on those supportive therapies as well? And then also our supportive care teams and community partners. So that's why I think when I say this feels very daunting, it's because it's not just chemo chairs. Yeah. It really is. It's going to have such a huge impact on so many people who are key partners and providers of care for patients on systemic therapy, that we really do need to make sure that we're purposeful, we have good engagement, and we have a strategic lens about all of the impacted areas as part of this plan.
Again, with the equity lens, you want the patients not only to get the right drug at the right time and all that, but the supportive care that they need, access to things that help them stay safe in their homes, advice on how to parent when you're going through a cancer treatment.
That's right.
All the things that major cancer centers can deliver, but don't exist out in the community, and yet you'd want to ensure that patients had access to those kinds of programs. So it's a very multifaceted plan that you have to work on. But it's daunting right now, I would think, too, because of the healthcare workforce. And we're short on nurses generally, and I'm sure there's shortages of well-trained chemotherapy nurses. And to address the future expansion is going to need more nurses and more pharmacists and more of a lot of people that may be in short supply at the present time. So you have your work cut out for you there, and that's just one component of this regional cancer plan. So,
that's right.
So we've touched on some of the key elements. Are there some others that you'd like to mention just before we perhaps wind up?
Yeah, I think another key element that we're really working on as well is streamlining processes across our 4 regional cancer centers. And another key element of this plan is really looking to not only the patient and care partner experience, but the experience of our providers as well, not only within the cancer system, but in primary care and community sites that are referring patients into a cancer center. And I think what we're doing is relying on the strength of our regional networks to advance some work to streamline and standardize the referral processes for patients to ensure that they can get booked into those consult spots as soon as possible and minimize the frequency of having to go back and forth for additional diagnostics. So we've started one of our biggest year 1 objectives that we're working on right now. It pertains to our new patient referral process for medical oncology. And we've had a lot of key learnings from this about how there was opportunity to streamline what would be minimally required for a medical oncologist to accept a referral based on the disease site of that patient. And we've come together as a region to take on a quality improvement initiative to change that and leverage the strength and approval of our committees to get standardized referral criteria that will be available on our regional cancer program website as a hub of like a clinical repository where primary care providers can reference and access and know how to get those patients in more seamlessly. And the other important part of this is just step 1 for inching us towards a central intake, which will be coming from a provincial lens, is really the mandate to try to move along to more of a centralized referral process that's electronic. So getting our region to be standardized and agree to our minimum referral criteria is step 1, and then eventually making it all electronic and centralized will be a really important piece of that as well. So starting with medical oncology, and then we'll be expanding into radiation oncology, surgical oncology, and making sure that we have patients who can access the care when they need to.
That's another huge project. And
yes.
There's some major barriers to it. But one of the big, criticisms of the existing cancer centers is that you can't get in unless you have a diagnosis of cancer. And yet the people who know the most about cancer and how to diagnose and treat it are in the cancer center. So it's up to family physicians and specialists in the community to work up a patient to a point where the cancer center will accept them. And that often leads to very long delays and the appearance of a very fragmented system. So if that can be overcome by these initiatives, that will be a huge step forward. So we're going to take a brief break for a message from the Cancer Assistance Program, and we'll be right back talking to Jennifer Smyth.
We'd like to take a moment to thank our generous supporters, the Hutton Family Fund and Banco Creative Studio, who make the Cancer Assist podcast possible. The Cancer Assistance Program is as busy as ever, providing essential support to patients and their families. We remain committed to providing free services for patients in our community, including transportation and equipment loans, personal care and comfort items, parking, and practical education. These services are made possible by the generosity of our donors through one-time gifts, monthly donations, third-party fundraising, corporate sponsorships, and volunteer opportunities. Visit cancerassist.ca to see how you can make a difference in the lives of cancer patients and their families.
We're back talking to Jennifer Smyth, the Regional Vice President of Cancer Programs, and we've been talking about how the new regional cancer plan will be rolled out and the different elements of it, and it's complicated and involves multiple sites across the region. We've never really defined what the region is we're talking about. I did mention the Hamilton, Niagara, Haldimand and Brant. It's a mouthful.
Yeah.
But that's a kind of a geographical area in southwestern Ontario. And you mentioned level 1, 2, 3 facilities, and that may be confusing to our listeners. So maybe you could expand on that.
Yeah, it's a good point of clarification. And in our region, so we do have 4 oncology or cancer programs. The Juravinski Cancer Center being our lead regional cancer center. That is our level 1 site. So we have chemo suite. We have 11 radiation units. Linear accelerators is what they're called. We also have a huge clinical trials department, and it's an academic focus there at that center. We're very fortunate to have a level 2 center, which is the Walker Family Cancer Center in St. Catharines. And they are a level 2, meaning that they do provide radiation therapy as well, in addition to chemo, and a bit more enhanced supportive therapies as well, like psychosocial oncology services to support patients. We're very fortunate to have 3 linear accelerators or radiation units there too. Then we have our 2 level 3 sites. So between Joseph Brant and Brantford, we have nearly 30 chemo chairs between those two sites that they're able to actually prepare and dispense their own chemotherapy drugs with their medical oncologists on site, some supportive therapies. They are trained, they are brought into our network of our regional cancer program to be able to deliver care on site for those patients completely independently of the regional cancer center. And I think, in addition to that, when we look at our region, we do have other partner sites across the cancer continuum that don't provide chemoradiation. But St. Joe's is a great partner for surgical oncology, particularly for thoracic, lung, esophageal, head and neck cancers. And we have Norfolk General Hospital, which has a small portion of cancer surgeries as well. And we continue to partner with those sites through our programs to make sure that we're providing oversight to the quality and access to care for patients for those services.
Another term we've used a little bit too frequently, perhaps, is systemic therapy. I guess a lot of people get confused by that. I try to explain it. It's drugs, various types that go through your system, hence systemic therapy. It's but they can take many forms, right?
Yeah, and so systemic we use it interchangeably with chemotherapy, but chemotherapy can be delivered a number of different ways now, right, as you mentioned. So you can have oral chemotherapy, you can have an injection, a needle, a sub-Q injection, or the traditional infusion ways. And that's where, when we look at our capacity plan, we need to consider, like I mentioned, that optimal location of where that patient can get that chemo, depending on the route of delivery.
Nothing is simple in oncology delivery these days, and I think the dimensions that have sort of expanded with these regional cancer programs from just focusing on kind of the technical aspects, having enough buildings, machines, pharmacists to prepare the systemic therapies, et cetera. It's really broadened out, and I think that should be very encouraging to people who are listening, and for those perhaps listening from distance where regional cancer programs don't exist, maybe a bit of a learning about what the art of the possible is, because it's really the integration of a wide variety of services that are helpful to the patient over the course of their journey, and even trying to identify risk factors, prevent cancer, or detect it early through prevention and screening programs. So it's a very broad-based program that you're responsible for. I'm surprised your shoulders aren't slumping down from the weight of all you're carrying, but it's an amazing bit of work that's being done. As we wrap up, maybe you'd like to comment on other aspects or things that you'd like to emphasize about our regional program here?
Yeah, maybe the last thing I'll close out with is, we have a renewed focus on how we are providing patient education as part of this plan, which I think is a huge component as well. We've started off on our cellular therapy transplant side of the house in hematology with partnering with previous and current patients to help us redesign the way we deliver our education to our patients. What we've heard from our experience information that we collect is that time and time again, patients just feel completely overwhelmed by the amount of information that they receive and the way that they receive it. So, we've partnered with an industry partner to support the development of virtual video patient education modules that are going to be done. I always call it TikTok style, because I think about, the frequency of which you can go through and watch videos that make sense to what you're really wondering about. And they're leading it in terms of what were the biggest things that they wanted to know as part of their education. And then our healthcare professionals are also contributing about what patients must know. And I think from this initiative, we're going to figure out how we can scale and spread that across all of the disease sites that are treated at the cancer center and then across the region as well, so that patients do have one trusted point of reference for all of the education that they maybe have been told, but it's just so hard to absorb in that moment.
Well, a lot of it goes in one ear and out the other because of the volume and the emotional state of the patient and the timing of when it's given. If you go in the first time to a cancer center to meet your oncologist, to have a consult, to hear about the extent of your disease and how it's going to be treated, it's just overwhelming, I'm sure, to most people. And it needs to come in small dollops at intervals as you can manage it, and be repeated too, because you only absorb a portion of it each time, I'm sure. I'm interested in the fact that you've referenced partnerships with industry several times. And in my experience, a lot of oncologists are very wary of working with industry. I've always felt that since they're the developers of the products we use, that we we should partner. You have to have a careful relationship, shall we say, but it seems to me they can bring so much resource to be helpful, and I'm impressed that you're actually doing that, and I commend you for doing it, because I think that they can be very helpful in bringing resources that make it better for our patients.
Thank you, and I think I do feel that as well. I mean, we do have to be very careful and clear on our terms of our partnerships with industry. But when you think about the drugs that we provide our patients are provincially negotiated. We're not individually negotiating them at the individual sites.
You can't be influenced.
I can't be influenced. I don't get to make that decision. So where we leverage our partnership is the focus on access, education, and quality. And where I think our industry partners, they're often in our partner sites more than we are. You know, they're there meeting with different oncologists or radiation therapists or chemo suite nurses. And when I think that we can leverage their ability to be in the field and share a common message about what are our educational needs of our teams and what is coming down the pipeline for access and what are each of the sites doing and where are they at in the state of their readiness, it's been extremely impactful in terms of strengthening the quality and access of care that we're providing to our patients. So we're going to continue to build on it.
Excellent. Well, we also have a partnership with the Cancer Assistance Program.
That's right.
And providing those various services I mentioned up front at the beginning of the show that make a difference to the cancer patient's experience as well. And we very much appreciate that partnership, and it's certainly a benefit to the people in our community. So we've been talking to Jennifer Smyth, the Vice President of Regional Cancer Programs. I want to congratulate you on all the things that you're leading in the region and wish you well with that, because although it's a very ambitious regional cancer plan you're going to roll out over the next 3 years, all those things will make such an important difference to the people in our community. So thank you for your work, and to all those at the Juravinski who are going to be activating this plan. Pleasure talking with you, Jennifer.
Thank you for having me.
You're listening to the Cancer Assist podcast, hosted by Dr. Bill Evans and brought to you by the Cancer Assistance Program. Wherever you are in your experience, we're here to provide help and hope as you navigate cancer prevention, treatment, and care. Help when you really need it.